we as the panel need to sit up here for about a half hour.
Okay, perfect.
You guys do want them to watch you as you All right. Well, good evening, everyone, and thank you for being here, sticking it through the first day. I'm excited about the evening activities, and again, want to thank Department of State Health Services for sponsoring this and for the food this evening and the ongoing support. So what we're going to do this evening is, again, we're privileged to have Dr. Ann Borders here from the Illinois PQC, and she's going to share her experience and in more detail on the work that they've done in Illinois to really stand up a great perinatal quality improvement collaborative, a real model for us. And so then probably about 7:30 or so, we're going to bring up a panel of folks here in the state of Texas and just have a discussion. What did we hear? What can we do better? What are some of those opportunities? And so with that, Dr. Borders. Welcome.
Thank you. Hello, everybody. Okay, so you have definitely heard a little bit about ILPQC today, and I'm excited to have this time tonight to share in a little bit more detail. We have a little bit more time to talk about how we do the work that we do, particularly how we think about launching an initiative, how we support hospital teams, and then talk a little bit about ILPQC in action and try to walk through a little more information about some of our initiatives. I haven't really talked anything about the initiative that we're really excited about right now, which is the opiate use disorder work that we're doing both on our OB side and our neonatal side, our immediate postpartum LARC initiative, and then I'll talk a little bit about hypertension. I got to talk about it today. How many folks are here who were not in the hypertension? If you were not in the hypertension initiative breakout, can you raise your hand? Okay, good. Actually, there's quite a few. So I'll share a little bit more than what I thought. So that means I'll just talk faster. Before I get started, I do want to take a minute to thank the organizers for today and the planners for today, because sometimes planners get overlooked, and I know that happens at our collaborative sometimes. So if you are one of the organizers or planners, can you just raise your hand? This day has been so exceptional. They're all busy organizing and planning somewhere. Thank you guys for all the hard work. Going into the details of putting on something like this is a lot. It's a lot of work, and it goes by in the blink of an eye, and it just took like a year of work. So congratulations to everyone for making this happen. So I'm known for talking about the magic of collaboration. It's like a buzzword. People laugh when I start saying it because they know once I start talking about magic, they're like, ugh. Anne's talking about magic again, but I really believe it. I think that when people come together and work collaboratively, magic happens, and that's why we see these improvements. So I don't have any conflicts to report. I do want to thank our funders, the CDC, the Illinois Department of Public Health, AIM, and also we have some funding as well from new funding from the Pritzker Foundation. So I'm going to talk briefly structure, launching initiatives, helping teams succeed, and then a little bit about ILPQC in action. Okay, so I talked earlier today about this model of ILPQC, that we're a collaborative of physicians, nurses, hospital team, public health, and other stakeholders implementing data-driven, evidence-based practices to improve maternal and neonatal outcomes in Illinois. I think it's really important that we understand what the collaborative is. The collaborative is not some committee that sits off somewhere and plans work for people to do. The collaborative is a hospital teams. They're a collaborative of hospitals, and the collaborative of hospitals gets to figure out, we want to do this work together. We are going to collect data to try to make us better. We're going to implement a toolkit. Now, the central team of ILPQC does a lot of work behind the background to launch initiatives and to help teams succeed, but the collaboratives are really that initiative. I shared this pillar drawing earlier today, but I just wanted to really hone in that all the work that we do in the collaborative, I really think fits in that model. Opportunities for collaborative learning, providing rapid response data with rapid response reports that people get in real time, quality improvement support to really help our team succeed, really on a foundation of leadership, advisors, stakeholders, and patients and families. We partner with patients and families consistently. We have about 6 patients advisors on our advisory work groups, and then we work really hard to get patients involved in the QI teams. We know that when there's a patient on a QI team, they improve faster, and so really trying to get that model out is important. We have a really focus on large statewide participation. I'm so impressed with Texas and what a wonderful job you guys have done at engaging hospitals across this very large state and getting people to show up and getting people to buy into the idea that change can happen when people work together. We have done that over time with ILPQC, and I think it's because we show that there's a lot of value to participating, and it's what all the cool kids are doing, so that really helps too. You don't want to be like the one hospital that doesn't participate. We had, so our face-to-face meeting that we had in May, we had 110 hospital teams there. We had 101 OB hospital teams and 70 neonatal teams. That was a big jump for us. Previously, we had 26 neonatal teams participating in ILPQC. We went to 70 this year, so it's really exciting. Again, I talked about this advisory group participation. We do a lot of things to get providers and nurses engaged in running the collaborative. So these advisory groups meet monthly, the second Monday of every month. OB used to meet for an hour, and then the team decided they wanted to meet for an hour and a half. So that's what we do. We've had 74 members over time, representing about 30 hospitals, and our neonatal advisory group has 31 members representing 19 hospitals. This is the milestones, and I'm not going to go through this in any depth, but I just wanted you to be able to see that we're not that old. We haven't been around that long. We started talking about ILPQC and trying to form it in 2012. A lot of running around to other states and asking them, how in the heck do you start a perinatal quality collaborative, and what should we do? Getting a data system built, getting a website, and then really launching our first meeting in 2013, and we're ecstatic when people came and really drank the Kool-Aid and really started wanting to do this work together. We launched the data system. We got the grant award from the CDC, and that allowed us to launch our first 2 initiatives, early elective delivery and neonatal nutrition. And then we moved pretty quickly into golden hour and birth certificates. We worked on optimizing birth certificate accuracy, which gave our teams a real opportunity to see what quick QI success feels like. And they really liked submitting data every month on their 13 variables. They were checking birth certificates versus the medical record and could really see rapid improvement. And that's when everyone, I think, got the bug for QI. We had 40 hospitals participate in that, and then the next year it went to 100 hospitals. We launched the Maternal Hypertension Initiative, which I talked about earlier today, and I'll talk a little bit more, in 2016, and we worked actively on that initiative with kind of everything we had. We really put everything into that, and all of our hospital teams did as well, and we are so proud of the work that our teams did. We were in active phase of the initiative for 2016 to 2017. We typically think of an initiative as a 2-year active phase, and then we move into sustainability. That doesn't mean we're done. In the sustainability phase, we spent a lot of time talking about helping teams get across the finish line. So it means if you haven't met the QI benchmarks yet, we're helping and pushing and pulling to help get everyone across the finish line, and we'll help everyone else get into sustainability, which means you have a way of implementing this in a system-wide way that's you're not gonna slip back. And we'll talk about that briefly later. We then started talking about the opioid crisis a lot, and our teams voted that they wanted to do the opioid initiative. This was a big undertaking. It took a lot of planning. And we launched it, we planned it during 2017, and then we launched it in the spring of 2018, and I'll talk a little bit more about that at the end. At the same time, we got funding to launch the Immediate Postpartum LARC initiative to help hospitals improve access to immediate postpartum LARC, and both of those have been a success, and we're now moving into year 2. So we just started figuring out how we're going to position ourselves for success in 2019, and our teams just voted at the annual conference on what they want to start with in 2020, which is cesarean delivery, optimizing vaginal birth, and also the equity bundle. But we'll vote at the end of 2019 to say, are we ready to move on? And teams may say, you know what, we want to do another year of opioids, but that's kind of how our collaborative works. The teams get to make the decisions. We say all the time, lucky for us, we're a collaborative. Let's just move the goal line. So if we want to change what we're doing, if we want to work on it longer, we all vote and we decide and we do it. Okay, I'm going to put this up one more time. I shared it briefly earlier. It's really important. People often see me as the face of ILPQC, but I am just like mostly the cheerleader. The work is really an amazing number of people who do the work from the ground up all across the state, and these folks really lead the way. Leslie and Justin are our neonatal leads. Patty Lee King is our state project director, who's been texting me while I'm sitting up here. Dan and Danielle, very confusing. Ideally, you don't hire people with the same name to do very similar jobs. And there are project coordinators. Dan runs opioid. Danielle does hypertension, sustainability, and IPLRC. And then Autumn Pro is our new hire, which is our nurse quality manager. And she does a lot of traveling around the state as well as all those guys. We provide really important services to our teams, and I think that that's the thing about being value added. We want our teams to feel that when they participate in ILPQC, they're getting a really good deal, which means they get to participate for free. We provide webinars I was just talking about the fact that we have a webinar every Monday. Our team is putting on a webinar between our neonatal initiatives and our OB initiatives and our advisory work groups. So we're putting those together, getting the data together. Wednesday to Friday is really moving those, getting them on my desk by noon on Friday, and then we'll have a final product ready to go Friday morning, or Monday morning, and then we have our webinars every Monday. We are reaching out and meeting with teams a lot. Our teams on those learning webinars, 2 teams usually per month do team talks on any given webinar. So that's reaching out to the teams, making sure that they're thinking about, are we going to present a PDSA cycle? Are we going to present our 30, 60, 90-day plan? How do we show our barriers, our challenges? And it's teams being really open and transparent. It used to be that no one shared their data. Now everybody shares their data. And that's just people getting really comfortable as a collaborative that we're in this together. We do a lot of face-to-face. So we're face-to-face twice. In the spring, we do our face-to-face meeting, which is one day OB, one day neonatal. It's really focused on the initiatives we're working on. We have breakout sessions. We work really hard at solving barriers and challenges and coming up with ideas and helping each other. Every single team brings a storyboard. So we have, if there's 100 teams there, there's 100 poster storyboards around the room, and we all go around and read what everyone's up to. Everyone has to include their 30, 60, 90-day plan on their storyboard. At the annual conference, we have a poster session, which people share their QI work that they're doing, which is also really important. So lots and lots of sharing and collaborative learning. Resources, our toolkits, we spend a lot of time putting the toolkits together. It's a lot of stealing. We just say, hey, Ohio, we love what you're doing with that. Can we take that and put it in our toolkit, and then we'll put it at the bottom, borrowed from Ohio or whatever we say. And we do that all the time. So we basically go through all the resources that are out there and try to take stuff that's confusing and pull it into really easy-to-eat bites for our teams. We do a lot of patient education materials, and we also share those from other places, and our monthly newsletters are in our data system, which I'll talk more about in a second. So the data system is what really drives our quality improvement. I think that was apparent if anyone was in the hypertension breakout. You could see how much our teams use the data to drive the quality improvement work with hypertension. They collect data on structure, process, outcome measures. They input it into our REDCap data system, and then they immediately get the REDCap data reports back that show how they've changed across time and how they compare to the rest of the hospitals in the state. So we put a lot of time into building these data reports. And I'll show when I talk about launching an initiative how we work with the teams to figure out what data they want to collect. The reports are really asking the question, what is the quality improvement work that our teams are trying to do, and what data is going to help them do that work? And how are they going to want to see that data so that they can share it? There's a little button that's a PDF so that they can email that data out to all of the OB providers at their hospital. They do a lot of sharing that data and using it. They post it on labor and delivery. They send it out to the administration. And they use it on their monthly meetings to figure out what's the next PDSA cycle, how they're going to focus the QI work that they're doing. I don't think that they could do the work that we do, kind of at the level we do it or the speed that we ask them to do it, without the data to really drive knowing where their issues are and what they need to focus on. Communication, we spend a lot of time, like I said, communicating with our teams, and I think the ability for the teams to kind of get messages that create a sense of collaboration, a sense of empowerment. We work really hard to make sure that our messaging and communication keeps everyone in it and excited about the work, but not overwhelmed. We want to make sure that we're asking people to do things that are doable and that we really read the temperature a lot to make sure that we're not overwhelming people, but yet we're pushing our teams to achieve quickly. This is our website. I encourage you to take a look at it if you're interested. This is like definitely a work in progress. If anyone has website skills, we always take helpers. But it has what we need there. So I'm going to talk a little bit about launching an initiative. When we get ready to launch an initiative, we do a lot of trying to figure out what our teams want to do. So the first thing, every year we do a survey about a month before our annual conference, and it's our yearly ILPQC survey. We have about 80 to 90% of our hospitals respond to the survey. It's a lot of asking them about the year, how it's gone, what they want to see different next year, what issues they've had, barriers on the different initiatives. But it's also about what they're thinking about for 2020 and what do they want to work on in terms of QI. And so we take the temperature basically of every hospital with that survey. Then we have our annual conferences, and also during the year at our meetings, we have state PQC leaders from other states share overviews of initiatives. So they come in and like we'll hear from Elliot talk about the optimizing vaginal birth. We'll hear someone else. So stuff that we're not necessarily working on, but we potentially could be working on in the future, we bring in and share and have our teams hear about it. And that really helps people start to think what seems like something we could do. We then discuss and vote on initiatives at our conference breakout sessions. So that's how if you would have been at one of our breakout sessions in November for our annual conference, the teams really are like 400 people in a room. Okay, these are our top 3. How many people want this for 2020? How many people want this? Anybody here wants to argue, wants to present a case why the rest of us should do something different? Anybody here think we should do a second initiative in addition to this? So there's a lot of like people standing up, and that's how we ended up deciding to do both vaginal birth and equity, because a group stood up and said, I think, guys, that we should think about adding an equity bundle to what we're doing with vaginal birth. And then people talked back and forth, and we said, okay, is there a consensus? We think we should add a second initiative. Everyone raised their hand. So we're not coming at them to say, hey, guess what, in 2020, we're gonna do 2 initiatives. It's really, this is what you guys decided. They may change their minds at the next conference, and we may push that back if it's too hard, but for now, that's what we wanna do. We then do a lot of buy-in building with our advisory work group, Perinatal Network, and a lot of engaging our stakeholders. We have a legislative advisory work group. We have meetings with the governor's office. We work with all of our agency leads. We work with March at Times, our community groups. We want everyone to feel like they have a part of what's going on so that no one's kind of feeling left out. We want to build ownership. Getting ready to launch. So getting ready to launch an initiative, ideally, we would have a year to do this. Sometimes we have less time if we have to push forward quickly. We identify leadership, so identifying clinical leadership. We like to select clinical leads, a combination of providers and nurses. Typically, we've had 2 nurses and 2 providers, something like that. And they're just an extra set of experts who help us develop our toolkit, our grand round slide set. It's just another set of folks who have expertise. Like, for example, for our opioid project, we have folks who are double-boarded, MFM and addiction specialists as our 2 of our clinical leads, and we have someone who works in community clinic, addiction clinic. So really getting those experts who we can just call at any time and help us is really important. We review resources and develop resources from other PQCs. So we typically do a series of phone calls with other PQCs who've done the initiative or thinking about it or have done some component of it to learn about the process, the ups and downs, and the resources. And then we do a big assessment of state and national resources, and that's usually like some summer intern who we can coerce into like spending a lot of time reviewing toolkits. And then we try to compile it together into a toolkit and a basic data form, and then we send all of that through our advisory work group, and they hash it out and decide, yes, that's good, no, yes, no, that kind of stuff. And then in the end, we have a basic toolkit and a basic data form. And what we do is, instead of just implementing that data form, when we start an initiative, we develop a wave 1 of teams who volunteer to start the initiative but not do any QI work. Their only job is to test the data system, so they're going to start collecting the data without doing any of the actual improvement work. And then we meet monthly, and they tell us yes, this is good, no, that's not good, I liked collecting this data, we couldn't collect that, you gotta change the way this is worded, that doesn't make any sense. So we spend a little bit of time making sure that we've got that right. We promote, really promote our nurses and providers working in the work of the collaborative. I've kind of focused on that a little bit today, but I think that's really important. You want people to feel ownership of the process and to be engaged, and also who wants to do anything by themselves? It's really better with friends, and so the more people who are working on something, it's really important. And that goes to even when you're doing the work at your individual hospitals. You really want to find a team, and you want to find people who you can partner up with to get this work done, and that's what we try to do at the state level. So when we're building teams, we recruit teams through the Department of Health. We spend a lot of time working with our regional perinatal network system and our team contacts. We work with IDPH and do a joint letter from the Department of Public Health and ILPQC. We send it out to every hospital in the state, explaining why this initiative is important, really about the buy-in, and then what the ask is going to be. So what is it we're trying to improve? And we say the team rosters will be coming out, we'll be sending it out, this is the timeline for doing it. That seems to do a lot to get the administration bought in that this is something important that both the Department of Public Health and the collaborative think is important, and they see a lot of everyone's on the same page, which helps making sure people aren't siloed. Teams submit the roster online, and on that roster, it says what the QI team responsibilities are going to be. You also have to identify all of your team members in that roster. You can't submit a roster unless it's complete, so you have to have a provider. You have to include everyone's contact information so we know how to get hold of people. We usually like to have a team lead, physician and nurse champions, and then really some interdisciplinary team members. And usually for any individual initiative, we say what they should have on that team. To engage hospitals, I think this, I like this is, Patty uses this a lot, Patty Lee King, our quality lead, engage, motivate, and support. And I think in some ways this is what Elliot was talking about earlier. We have to figure out how to motivate people to do this work. And I think PQCs are motivating hospital teams, and the hospital QI teams are motivating the people at their hospital, right? Your providers and nurses. So this whole idea of engage, motivate, and support, I think really transcends the work that we're trying to do. So engaging is trying to really engage people in the process of the initiative and being leaders at the collaborative and at the hospital level. Doing a lot to develop hospital buy-in. We want to make sure that we're breaking the work down into key steps. I talked about that earlier, but I think that's really important. I like when Jean was talking about you can't eat the whole elephant at one time, and that's what a bundle is. So we really try to break this work down. If you were in the room when we were talking about the hypertension initiative, I didn't talk about we're going to implement the entire hypertension bundle. I said we're going to do 4 things. And so we try all the time when we're talking to our teams about the work that we're going to do, we're always like, we're going to do 4 things, or we're going to do 5 things. You know, these are the things that you're going to work on. We want also really try hard to demonstrate frequent examples of success. So every single month on our webinars, we are scouring the country, literally, for teams, nurse or physician teams from other states who have done this work, have done it successfully, and can share how they did it and have a little bit of, like, you know, joy in their voice. No one's like, we really try to avoid anyone who's going to be a real downer. Like, if anyone's like going to get on and be like, this totally sucks, this is so hard, we never could do it, then we're like, we screen those people out. So we really want to have, like, we want to encourage that this can happen. And we have to, if we don't have, and if there's not examples of people out there, then we're barking up the wrong tree. We need to be doing things that others have shown are possible. And when you hear the story of a nurse, charge nurse, or a team lead from a random nurse in California or New Hampshire or Vermont, she says, this is how I did it, this is how I got my team on board. It's not me telling people you can do this, it's some nurse from New Hampshire. And that actually is really, really helpful for our teams to hear. And then also the team talks, where teams are sharing what they've accomplished. Incredibly motivating. The most important thing we do is having our teams hear from other hospital teams who've been successful at getting things done. And then support. This is where the collaborative learning, rapid response data system, and then QI support to ensure that equity of quality improvement work. So that's really, in a nutshell, I think, really important concepts for ILPQC. We use the IHI Breakthrough Series, and so thinking about how to do a PDSA cycle, it makes some people scared just to hear anything that sounds like a PDSA cycle. And so we really try hard to break it down and do something super easy. Like, an example would be you're trying to implement a new validated screening tool to screen for opioid use disorder. and you are really overwhelmed how to do that. So you print out the screening tool and you sit down in your OB office and you say, we're going to try this today, this paper version, with 3 patients, and we're going to try 2 different nurses doing it and 1 provider doing it. At the end of the day, I'm going to ask you all questions on how it went, and you tell me what you think. And the next day, we're going to try a different tool, and then you're going to all tell me which you thought was easier and better, and then I'm going to think about the process flow, and that would be a PDSA cycle. So we can do things really simply and small, and that really helps our teams feel not overwhelmed. This is the timeline of initiative launch. It's a little small, but so hospital teams vote for the next initiative, which I told you guys about. We do the initiative development. We set up aims, our key driver diagrams. We develop a toolkit and a data form. Then we recruit. So usually that's kind of hopefully in the year after we vote. So we just voted on 2020. We usually start recruiting for Wave 1 in December and January, and we launch our Wave 1 teams always in January. It's just kind of what our teams expect. We do things the same way, and it seems to help. So we launch Wave 1 in January, and our Wave 1 teams start data collection and trying the data form, and they meet once a month all together, January, February, March, and April. And that's, the teams just take turns sharing with us what they liked and didn't like about the data, and they basically try to produce an optimized data form by April and optimize data collection strategies. So then, really exciting, when we launch the full initiative for the whole state and we do our big face-to-face meeting, we already have like 25 hospital teams who can be like, hey guys, we collected this data, it wasn't so bad, this is how we did it, this is why we thought we should do it this way. So we already got a little group of experts. They haven't done any of the QI work yet, but they've really broken that seal of doing the data collection, and they've already become experts at it, so they can share. And so we've already got some collaborative learning going on. We typically launch our initiatives with a 2-hour webinar kickoff for the whole state in April, and then we meet together as a state in May. I'm down in Springfield. So helping teams succeed, gotta watch the time. So our quality improvement strategies. You know, I think that you've probably been getting this, but we really want to engage folks and develop folks working together. We want them to feel a part of the initiative from the very beginning. We develop multidisciplinary hospital-based QI teams, making sure that they have all the different components they need. And then these monthly collaborative webinars that we talked about, you know, getting the national experts on the phone. And like I said, national experts can be like, you know, Nurse Molly from Florida, who's really good at figuring out how to get women identified with the screening tool or something. This is an example of a breakout section, the picture on the bottom. I think that's a breakout at one of our face-to-face meetings. The 2 people at the top are OB breakout lead and a nursing breakout lead. And again, these folks may not know anything about the topic or a little bit about the topic, but they're facilitating this discussion. We always do them in a circle, and we always have a mixture of providers and nurses in the room for our breakout sessions. The top is one of our poster sessions. And again, we give out a lot of awards with ILPQC, and we do, I think you can see there's like a big white ribbon like you'd get like at a state fair or something. So we do, that's me coming from Iowa. We give big like state fair ribbons to a series of people who win our poster contest. We disseminate toolkits. We do all the toolkits at our face-to-face. We print them out and give everyone a binder. I know they talked about binders earlier, and it's not the cool thing to do, but we do it both online and print it out because our teams really like having a binder. And we spend a lot of time making the toolkits work for people, and people love leaving the face-to-face meeting with their toolkit. We do a lot of support, and so these are 2 support things I just want to make sure you're aware of. I think I talked briefly about QI topic calls. Our teams kind of bring up issues that they're having, like engaging the ER on identifying women with severe hypertension. That was an example of a QI topic call. And the QI topic calls, whereas the webinars are very organized and have a big slideshow and me talking and people coming from different states coming on, and the QI topic calls are just a discussion. We have a champion who is a team that's been identified who's working on this issue and having some success. And then we get about 20 other hospitals, and it's an hour of everyone talking to each other. And it's a way to break down our big collaborative into smaller groups to really share and focus in on issues that they're having. So it's small topics and small discussions to move people forward and make people not feel alone. The QI support calls are one-on-one. And that's where our teams review the data and how hospitals are doing. They schedule the QI support calls. It's been really positive. I don't think anyone feels judged or alarmed when they get these calls. They just kind of feel relieved and happy that they're getting some support. The teams really focus on data review. They try to help them think of a small PDSA cycle to move forward. And most importantly, they develop a 30, 60, 90-day plan, and they follow up with the team. So what are the key steps for success? We say building a multidisciplinary QI team, assess where you're starting from, so make sure you get baseline data, plan where you want to get to, so make a 30, 60, 90-day plan, which is basically setting your goals and aims. Try a small test of change, don't be scared, just start with something. The most important thing is to start and to do something small. If you're trying to change your entire system and implement a huge validated screening tool in every single outpatient birthing and your labor and delivery, it's going to stall up in forms committee for like 2 years. So start small. You want to collect data, structure, process, and outcome measures so that you can track your progress, identify your challenges, identify your successes, and celebrate them. And then also for compliance, you want to make sure you can track sustainability and compliance. The rapid response data reports allow us to show change from baseline and the comparisons across hospitals. It's really a key for us, at least, in driving the improvement, and then learn from other hospital teams and make sure we are sharing and learning. People asked me today about buy-in from providers, particularly, and getting them to do the work and to participate. We sell the initiative to OB providers. Why are we doing this work, why it matters, what they need to do, and how will their compliance be monitored. That's another really important thing. But we find that our OB grand rounds works a lot for getting OB providers who are recalcitrant and don't want to engage to really feel like they should be doing this work. And we have a group of, a speakers bureau of OBs from around the state who have volunteered to give our grand rounds. As long as they don't have to come up with a slide set, they're perfectly happy to go to a nearby hospital and like give a grand rounds. System changes that assist the clinical team doing the right thing every time. So you may have folks who don't want to do the right thing, but you set up a system that makes them do the right thing every time, and that's incredibly helpful. So the protocols, checklists, order sets, debriefs, EMR prompts. We also have escalation systems, whereas if a nurse identifies a patient with severe hypertension and the provider says, no, I don't want to treat them, they can escalate up the chain to someone else to say, I have a patient who has severe hypertension, they need to be treated, and I haven't been able to activate the hypertension protocol. Culture change needs both provider and nursing staff education. If you're trying to do just education alone, it doesn't work, but education married up with system change is where the real magic happens. So this is grand rounds, e-modules. AIM e-modules have been incredibly important to us, and a lot of the education things from AIM have been the really what we've used primarily to educate our providers and nurses. And then the active monthly review is really important. And engaging those OB providers, a lot of our nurses will bring the monthly data to the OB meeting and put it up, particularly the data that shows how they compare to other hospitals, because everyone thinks they're doing the right thing. We're all in this to like take the very best care of patients that we can. So if you tell someone that they're not taking good care of a patient, whether it's hemorrhage or hypertension or something else, they're not really gonna believe you. But if you show the data and where you are at baseline, how you're improving or not, and then if you show how you compare to other hospitals in the state, it's pretty stark that it's clear if you need to make improvements. I can't encourage you enough about engaging patients and families in the work. We've found a lot of success with having patients. The patient stories have been so meaningful. We try to have a patient story at every single annual conference. Our patient come to annual conference, and they always steal a show. Every single year, the patient talk has been the favorite talk at annual conference. And we really have found a lot of success with getting patients engaged in our QI teams. We do a lot of recognition. So this is a really happy team that won a banner at one of our annual conferences. So FHN Memorial Hospital is committed to improving the quality of care for moms and babies. These went up in like lobbies of hospitals all over the state. We literally had like TV news cameras going out, like particularly in smaller communities, to come like film their banner going up. It was really exciting. So people were just really falling over themselves to get these banners, which was awesome. So I'm going to talk really briefly in the time I have about some of our initiatives. This is some of our teams in action at some of our in-person meetings. So I'll talk briefly about hypertension success and sustaining that work. I'm going to talk about that last just because a lot of you heard about it earlier at the breakout session. I do want to talk briefly about M&O and ILPLRC, which were our two big new initiatives that we launched in 2018. And for M&O, that stands for Mothers and Newborns Affected by Opioids. When we first started this work, there was a lot of talk about doing an NAS initiative. We really quickly realized this is not about the babies alone. It's about a mom and a baby who have an opiate use disorder, or a mom who has an opiate use disorder, and a mom and baby who are affected by opioids. And so we've launched this for both OB and NEO, and we've used the term M&O. So I want to briefly make sure that people understand, and I'm sure you're having this issue here, opioid overdose is now the #1 cause of maternal death in Illinois. In fact, at our recent MMRC meeting last week that I sit on, we had to have a conversation about the fact that the number of overdose deaths from 2016 to 2017 have now doubled again, and we don't have the capacity in our MMRC to manage all the maternal opioid overdose deaths. And so trying to figure out what we're going to do. Like, do we only take every other one? So there's this real, I mean, it's unbelievable. The data hasn't been officially released, but once it's been finalized, preliminarily, we had a 1,000% increase in maternal overdose deaths in the last 10 years in Illinois. So this is a real crisis. And I think I was describing this at lunch. If someone told you that 20 women in Illinois died last year because they had diabetes and they didn't get treatment, we would all just be like, oh my God, like, let's all run home right now and go out to our office. And every single patient with diabetes we found, we would be making sure they got insulin, and we'd be following them around, you know? And that's what's going on with opioid use disorder, right? Or if 20 women hung themselves in pregnancy, and you're saying, people would be like, we've got to screen for depression, and we've got to treat depression. And that is what's going on with opioid use disorder. But the problem that's happening is that we all think that opioid use disorder is not an obstetric issue, and that we really just need to call a social worker and make sure that PEDS knows that this baby may have an NAS and needs to be screened. So we're seeing, I think, we really have to take this on, that we have work to do in the OB world, and that we have to take this on as our responsibility. And so that's what the work is doing with M&O. So this is the 7.8, that's the 2016 data. So if you can imagine where that 7.8 number is, I'm gonna get the 2017 data in 2 weeks, and it's doubled from that. This is NAS going up alongside that. The most important thing to understand about OUD is it can happen to anyone. It's a chronic treatable brain disease that can be successfully treated with medications and comprehensive care and recovery support. It's estimated that 1.9 million people had an OUD related to prescription pain relievers, and estimated 586,000 an OUD related to heroin use. And so you can't look at someone and know that they have opiate use disorder. We have to have screening tools in place to be able to identify these women early in pregnancy and again on labor and delivery. And we have to see this as a treatable disease, just like diabetes. It'd be like if you saw someone in your office, you screened them for diabetes, they were screened positive, and you were like, oh, I hope someone helps that person. You know, that is what's happening. So we have to take responsibility and do this work. So we've launched the M&O initiative. This is harder than hypertension or hemorrhage. It's definitely harder. It's more complex. There's more barriers to break down. The work is harder, but we have a crisis in front of us, and we have to take it on. So we have 107 hospitals participating in M&O. It's 101 OB hospitals and now 88 NEO hospitals. And we have about 150 participants per month on our calls. And we had the face-to-face meeting in May where we discussed this, was sold out. Our goal is to increase pregnant women affected by opioids who are identified, linked to care, and receiving MAT, which is medication-assisted treatment, by delivery. We want to optimize the clinical care that pregnant women are receiving through patient and provider education and implementation of care checklists. There's things we need to do for these moms in prenatal care when they come to labor and delivery. We need to make sure we're doing it, and that's where the checklist comes into place. We need to increase non-pharmacologic care and decrease pharmacologic treatment for the opiate-exposed newborn. That's through really engaging mom and eat, sleep, console, rooming in, and breastfeeding. So we want to increase breastfeeding rates for moms. We also want to increase safe and optimized discharge plans for opiate-exposed newborns to get these moms and babies home together. And then we also have a component around prevention, which is really trying to reduce the number of opioids we're prescribing for routine deliveries, and make sure that all of our providers are using the PMP lookup when they're prescribing an opioid. So I'm going to kind of go through this quickly so we have time to talk. So we're going to increase validated screening and linkage to MAT. So we're implementing a universal OUD screener using a validated screening tool as recommended by ACOG, both inpatient. So when people arrive on labor and delivery, we want them to be screened, and as early in prenatal care as possible. So basically, all of our teams are implementing these validated screening tools in the inpatient setting and in the outpatient setting. We're doing the expert protocol, which is basically saying, how are you going to respond when someone's screened positive? So it's screening, brief intervention, and referral to treatment. You need to counsel moms about what it means to be screen positive, assess them, their opiate use disorder, figure out what they need, and that's expert, and you can get reimbursed for that outside of the maternity bundle. We want to map local and available resources. People don't know where to send people. And so we're asking every single hospital to map their available resources to figure out what MAT, behavioral health counseling, et cetera, are available. And then they share that with their ER, their labor and delivery, and all of their affiliated prenatal clinics. We also are asking them to standardize the process and set up a protocol so that when they identify screen positive, they know how they're going to navigate these moms to care. So it's not enough just to find them. This is our optimizing care for moms and newborns. So it seems like a lot, but this is our OB and neonatal all together. So we're going to standardize provider and nurse education on OUD and also on stigma and bias. We really have to train our OB providers that this matters and that when they approach patients with stigma and bias, fewer patients get good care and they turn patients off. And so if we're going to get patients to trust us and to go in, get on MAT, come in for care, we've got to really understand stigma and how it impacts pregnancy care. We have to standardize patient education. We have a lot of great handouts that our teams are using. We're using the OUD clinical care checklist to make sure our patients are getting offered Narcan, are getting Hep C screening, and are getting the standard consults with peds, with social work. And our neonatal teams are working on standardizing the identification and assessment of opiate-exposed newborns, increasing maternal participation in opiate-exposed newborn care, optimizing non-pharmacologic care, the Eat, Sleep, Console model, standardizing farm treatment, and then safe discharge. I'm not going to talk about the neonatal teams today just because I don't have enough time, and then there's some prevention work that I mentioned. This is what it looked like. We launched Wave 1 teams in January. They worked through April on the data form. In April, we did our 2-hour webinar to introduce M&O to initiatives to teams statewide, and then we had over 300 participants, over 100 hospital teams that showed up, and they did storyboards and really talked about launching the initiative together. In June, we started our monthly initiatives and baseline data collection, and we're moving forward. Briefly, that's our toolkit. You guys can find it on our website if you want to look at it. This is some of our educational materials that are really helpful to teams. We actually did focus groups with patients. We're really proud of this work. We did in 3 or 4 cities, we did focus groups with moms with had babies with NAS and NICUs, and we used the moms to figure out what they wanted to be educated about, and they helped us build these materials or take materials from someplace else and make them better. This is the AIM bundle, which our teams also utilize, and then some of the AIM resources, which have been really helpful. So the resources that go along with the bundle are really important, and they're all a part of our toolkit. So the work so far that we've done, so we've worked on implementing it. This doesn't mean that our teams have completed all this work. This just means what webinars we've done and what our teams have started working on. So we did a webinar on implementing a validated screening tool, implementing expert protocol, completing a mapping tool, inserting a checklist into your EMR in the outpatient and the inpatient setting, and then standardizing patient education, and then stigma, bias, and trauma-informed care education for providers. These are key strategies. I'm going to kind of skip through this, but when I talked about trying to take things down smaller, you'll notice we'll go smaller and smaller. We start out like you've got this big bundle, and then I talked about those kind of key things, and now this is getting smaller still. These are key strategies. So we really want to take it from something big and make it easy for teams to be able to launch onto. So they can make their 30, 60, 90-day plan from trying to accomplish some of these things. This is our OUD protocol. This is what we want teams to be able to activate anytime that they identify a mom with OUD. So you screen and document the positive result. You provide expert risk assessment and brief counseling, benefits of treatment, next steps for linking the patient to care. So that's the expert. And then you activate a care coordination or navigation to link moms to MAT, addiction services, and behavioral health support. This is really important. We're really trying to figure out how to get this navigator in place, whether it's a social worker, a nurse in your clinic. These moms are going to pop up in private, fancy clinics full of wealthy moms. They're going to pop up in FQHCs. They're going to pop up in the ER. They're going to pop up in labor and delivery. on an antepartum floor, you're going to find a mom who has an opiate use disorder. And we need to be able to figure out in our system, wherever that mom is and whoever's office she's in, we have a way of activating this protocol. So we're trying to get people to develop a phone number or some way to activate this protocol. We want to insert and complete the OUD clinical care checklist in that chart, make sure she got Narcan, Hep C screening, the consults, and then finally we want to make sure she got the patient education and the newborn peds neonatology consult. There's a lot of barriers to treatment. I'm not going to go through that, but there's a million reasons why mom might not be able to get MAT. Our job is to bridge her across to the MAT. We do that by mapping local resources for MAT for providers and support services. We establish a process flow to link moms wherever they are in the prenatal, labor and delivery, postpartum continuum into this kind of care. And we also really need to expand the number of buprenorphine providers. Jean Mahoney has been really instrumental in this. ACOG has come out, I think we've done 3 trainings, 4, 3 or 4, 3. 3 trainings. We trained 70 OB obstetricians this year to get their buprenorphine waiver in Illinois. Just in this year, we have more trainings planned for 2018, hopefully. Can't impress how important that is, because if our OB providers can't prescribe buprenorphine, these patients are not going to get it. So what data are we collecting? So this is really important. This is what that Wave 1 teams decided upon. So our OB teams, they're collecting every woman who delivers who has an OUD diagnosis. We collect some key process and outcome measures by chart review. We also do a random sample of 10 charts from all deliveries. The reason that was decided upon is we're not going to be able to see if people are screening and documenting for OUD unless you look at all deliveries. If you just look at patients with OUD, of course people identified them with OUD. They have OUD, you already know it. So we're looking at a random sample, and that's how we're checking if people are screening and documenting universally for opiate use disorder. Our NEO teams are collecting data on all opiate-exposed newborns, and then all of the teams are doing structure measures into our data dashboard. And that's the key strategies. Have they implemented the key strategies yet? And it basically goes from red, you haven't started working on it yet, yellow, you're working on it, and green, you implemented it. These are our project aims, and I'm going to have to kind of go quick through the rest of this so we have time for our panel. But this is important, I think. So this is what we're asking teams to accomplish. Increase the proportion of all pregnant women screened with a universal validated screening pool during the prenatal period and during delivery admission to greater than 80%. We're at 40%. So we've got ways to go, but we know that our teams can get there. So we have to implement this universal screening tool, and you have to do it with all patients. And that's a big ask because you're asking private offices and clinics and everyone else to get this implemented. Increase the proportion of women with OUD receiving MAT prenatally or by delivery discharge greater than 70%. Increase the proportion of women with OUD connected to behavioral health, counseling, and recovery services. Increase the proportion of women with OUD who have an OUD clinical care checklist completed, either prenatally or during the delivery admission, or basically by the time they're discharged, we want that thing completed. Increase the number of women who've received Narcan, contraception plan, Hep C screen, behavioral health social work consult prenatally or during delivery admission. So even if you don't get access to it and get this done prenatally, we want labor and delivery to take up the mantle and get it completed during that delivery admission. Increase the proportion getting a pediatric consult, and then finally those that get education. We started out pretty dismal. This is what our baseline data looks like. Only 3% of women had a documentation of screening of opiate use disorder when we did our random sample for the state. Only 40% of women who had an OUD diagnosis were on MAT at delivery. And again, that's like only 40% of women who were insulin-dependent diabetics on insulin. Only 2% had received Narcan counseling and prescription. Again, this is the #1 cause of death in Illinois. 40% have been screened for Hep C, even though that's standard of care for these moms. So we have a lot of room to go, which is exciting. So this is, I'm just going to show you quickly some structure measures so you can show, important for teams to show success. This is a hard initiative, but the structure measures are showing success. The green, what you see is every single month, more teams are getting a standardized screening tool implemented on their labor and delivery. Super exciting. So you started out, only 5% of our teams had one, and now we're up to 36% as of the end of December. Having an expert protocol in place, again, you see that progress tracking across the state month by month. More and more teams are starting the work and getting it implemented. This is screening for OUD on labor and delivery documentation. That's that random sample of 10 charts. you can really see rapid improvement. And I think this is, again, that data that's driving this rapid improvement. So you can already see the red is missed opportunity, not screened at all. The yellow, they had a single item question like, do you use drugs? Yes or no? That was the yellow. And the green was there documentation of a validated screening tool, which is the ACOG standard of care. This is having your mapping tool done. This is having standardized education plan in place for women with OUD. So again, we're at 23% of hospitals. This is having provider and nursing education completed on the OUD care protocols. So we're at 45% of nurses, 31% of physicians. As we ramp up our grand rounds, which is what we're doing in 2019, that number is going to go up. This captures everything we're going to be doing for MNO in 2019. The key strategies, remember I said we keep getting smaller and smaller. I started out with a huge bundle, then I got that one page, and really you can distill it into teams should be working on screening, expert, mapping, checklists, and education. So that's when we ask if you need the elevator speech, that's what teams are working on. That's what we covered in 2018. These strategies is what we're trying to really push on. It's not enough just to have those system changes in place. We have to build trust and reduce stigma. We have to improve patient navigation for MAT and support services. We have to improve engaging providers and doing that checklist and making sure they understand the clinical care they have to do to increase buprenorphine prescribing. And we need a standard system-wide response for screen-positive patients, activate that OUD protocol. And all of that should help us increase the number of women screened and linked to care, increase the number of women on MAT, increase the number of women with the completed checklist, and increase the number of women engaged in opioid-exposed newborn care. Okay, I'm going to skip through the LARC work, so we have time. I'm just going to say that we're doing the LARC initiative. We have 17 hospitals. These are the key areas that our teams are working on. We've done webinars on each one of these topics. We started in May, and people initially told us we needed 2 years to implement. We said, we need wave 1 to be implemented in 9 months. But our teams are up for the challenge. They're, at this point, pretty well-versed in QI. And we now have all of our teams are going to meet the go-live goal by March, which is really exciting. So these are some of the things that they've worked on: billing and coding, stocking, ILPLARC protocols, and then the comprehensive contraceptive counseling, which was a big discussion this afternoon. Really important, patient-centered. What does a woman want? Understanding all of her contraceptive options. The goal of this is not to get everyone to have a LARC or everyone to have ILPLARC. It's to reduce barriers to access to care. And we really want to improve postpartum access to care for women. And one of the tenets of that is making sure that women have access to LARC when they want it. This is just one slide to show you success. So this is getting ILPLARC on formula. Look at that IUD one on the left. How exciting is that? You see every single month we got more of our teams to get the IUD on formulary. That's just a lot of work from the team, a lot of supporting, and a lot of what happens when you're doing this together. If it was one single hospital, it's just not very motivating. You could sit in a meeting talking about this for like 2 years and nothing happened. But when you have 16 teams, you'll be like, by God, we've got to get this going by March. That's the deadline. Everyone's making it happen. So we are calling for ILPLARC Wave 2. We're expanding it to the rest of the hospitals in the state. And another thing that we're excited about is our trainings. We've been doing those in coordination with ACOG. We've got 3 more trainings planned for 2019. We're also launching something called IPAC. We have a large number of Catholic hospitals in our state who are not going to be working on immediate postpartum LARC. And at our face-to-face meeting, they came to the breakout session. They were like, what about us? We're part of this collaborative. You can't do something that we can't. How can we participate in this? So we said, okay, let's hold a series of calls and find out what you want to do. So they chose what they wanted to work on is improving postpartum access to care, which is the goal of universal early postpartum visit at 2 weeks. Now, for a lot of those women, they're going to be then able to access contraception at that 2-week postpartum visit. But for the hospital itself, it can really see themselves focused on getting women to a postpartum visit at 2 weeks. So it's an umbrella that everyone can stand under, regardless of, culturally where that hospital fits. And we're talking a lot about that ACOG committee opinion, as was discussed today. I'm not going to spend much time on hypertension since we talked a lot about it earlier, but just for those who weren't here, the thing that we did with hypertension was we broke it down, and we just did 4 things, and our teams did it really well. We reduced time to treatment of severe hypertension to under 60 minutes. We improved postpartum patient education, so when women went home, they really understood what preeclampsia was and what the signs were and what they were supposed to do. We improved postpartum patient follow-up. We had everyone back within 10 days for a blood pressure check. And then we asked our nurses and our physicians when they treated someone for severe hypertension and pushed that IV, that they would turn to each other and say, how did we do on time to treatment? Because we really wanted to change culture around the idea that severe hypertension is an emergency, and that we have to gauge how we're doing on time to treatment is how these women are going to do. We did this with 110 teams, and we did it from May of 2016, and then December 2017 was the end of active phase, and we moved into sustainability for 2018. This is really the idea behind both the hypertension and the hemorrhage, and I think Elliot talked about that a lot today. It's down here where all this stuff at the bottom is what we're trying to avoid, and that's why we're trying to do the hypertension work, is to really reduce severe maternal morbidity. This was our project aims. I'm not going to spend a lot of time doing it. Increase the proportion of women treated for severe hypertension to less than 60 minutes. When we started, we were only at 40%. We were going to hit above 80. Increase the proportion of women receiving preeclampsia education at discharge. Increase the proportion of women with follow-up appointments scheduled within 10 days of discharge. Increase the proportion of cases with a provider-nurse debrief. And then our outcome measure was reduce the rate of severe maternal morbidity by 20%. One of the things you guys can see with these initiatives is over and over again, we're being very specific with what we're asking teams to do and what we're asking them to accomplish. And then we're tracking it and showing them if they're doing it and then helping them if they're not. So I think it's really helpful for QI success if you know exactly what you're trying to accomplish, and it's not this kind of big, overwhelming, I'm not quite sure where to get started here, but really breaking it down. And that's where the Perinatal Quality Collaborative or the group that's working on the initiative can really help by saying, this is how we're going to focus the work. And that's what we've been able to do, I think, with our teams. This is the success that I showed earlier. So the folks who weren't there, we started out on the left-hand side. That's the 40% is where we started at baseline. The red is missed opportunities, meaning someone had severe hypertension, they never got treated. The orange is they got treated, but it was greater than 60 minutes. Light green is treated within 60 minutes, and the dark green is treated within 30 minutes. So for the most part, our teams were able to achieve treatment within 30 minutes. We went to sustainability December 2017. We actually hit our goal of 80% in October 2017. We never looked back. And that's really what sustainability looks like. Like if you are doing like a test case on how to sustain QI, like that is like a beautiful thing. Like sometimes I cry literally in front of I'm like, oh my God, you guys, it's so amazing. Like the teams we can't take it sometimes when we have these meetings and we review the data, the teams get so excited and I get excited. So this is, what I did show tonight, which I showed today, is the education also increased significantly. We started at about 30% of women receiving education. We're now hanging out above 90%, and we have been since we moved into sustainability. The same for our postpartum follow-up. We started out around 30%. We're now well above 80. Debriefs, we got to our goal. We set our goal that we would debrief more than 50% of cases, and we hit that goal. The big news was that we were able to reduce severe maternal morbidity. This is from chart review data. So starting out, we were at 15, 17% when we started from our baseline data. And then the last quarter of the initiative, we were down to 9%. And these are really serious issues, the severe maternal morbidity based on the CDC definition. So a really big reduction in severe maternal morbidity, which is a 40% change. And then we just received our hospital discharge data through 2017 in the last month, and that showed where we had been increasing severe maternal morbidity. This is for all women with a hypertension diagnosis for the state of Illinois. We reduced by 50% from 2015 into 2017, which is really exciting. The things that our teams felt were most important and helpful to them were the toolkit, reviewing the data reports with their teams. Remember we said that they used the data and they reviewed it every month? That's one of the number one things they said helped them do this work. The e-modules, Jean made the list, top 3 things are most helpful. Our face-to-face meetings, and then the team talks on the monthly webinar. So you notice it's not me talking. It's not like, oh, we really loved hearing more from Dr. Borders. It's really, we like hearing from each other. That's the most important thing. And they want more QI training. That was a big request. And these were the elements of our toolkit that were most helpful: the treatment algorithms, provider staff education, and the order sets. These are some of the awards that we did. I'm not going to spend any time on that. And then this is the sustainability model that we built. We had each team submitted a sustainability plan. You had to have those 3 components. We actually made draft sustainability plans, and they just had to like fill in the blanks, but they all implemented them, which is awesome. The compliance monitoring were these things. They tracked these things and submitted it into our data system. New hire education were the e-modules, and then ongoing staff, almost all of them did simulations and drills on labor and delivery on severe hypertension. This is that woman that Elliot showed earlier that was a NICU nurse who died. And I think We really try to use stories all the time, but we say quality matters, every patient, every provider, every nurse, every unit, every time. And it's just to remind us that any patient in front of us can benefit from the QI work we're doing, and we have to do it right every single time. And that's really the call to action for all of us. These are our goals for 2019. We're going to continue to sustain our work, support the QI work, expand and engage our teams, and continue the strong support of QI at the hospital level. So in conclusion, ILPQC is a collaborative hospital teams working together. Collaborative is a team of providers, nurses, staff who drive the work with input from all. ILPQC provides opportunities for collaborative learning, and the teams provide the magic of collaboration, belief in the importance of data, commitment to evidence-based practice, and the drive to do better together. So I want to thank you guys for listening, and sorry that I went a little bit over.
Well, thank you. I think that was a great summary of the work that you guys are doing. Very, in some ways intimidating. A lot of work that's taking place. I'm going to ask the rest of the panelists to come forward, and want to get some of their reaction to the work that's taking place. And so, please.
While people are coming up, I will say that, we just started this work, and I think that it seems intimidating, but I think the most important thing is to start somewhere.
Could you talk a little bit about how you, especially on the first ones, went from almost theoretical and planning to getting it statewide and getting, and some, for us in Texas, obviously big state.
Big state.
But 400,000 births, 250 birthing hospitals,
Yeah.
about 10% of all the births.
I think, is this on, guys?
And how do you go from taking that from a few hospitals that are leading in this field to getting all the hospitals and kind of the role between
Does that work?
what you do in the state in order to get that accomplished?
I think that first, I think two things. We have a regional perinatal system, so the way that you guys are breaking down into, are you calling it cohorts? I think it's really important. We have a regional perinatal system, so we have 10 networks, and so we were able to really get people talking at that network level and buying in, and that seemed to make a big difference. And then I would say when we got together at that first big QI meeting, and we were able to get some physician leaders there from different places who showed up and thought this seemed like a good idea, that seemed to build momentum. And then giving people jobs, making them feel a part of things. I think all those things mattered. And I think that when we started out with birth certificates, it wasn't very clear that we were going to be successful. It was like, okay, we're doing a birth certificate initiative. Like, that's not very sexy. People are just kind of like, really? But because the QI success was working, people really were like, this is a model we can use to take on hypertension. But I think that using the regional perinatal system, where small groups where we could communicate with them effectively was really important. Getting people to come to a meeting face-to-face and feeling like they could buy into some of the excitement and take that back home with them. And then trying to get some physician leaders from around the state to participate and feel like we had small things that they could do that would make them feel important.
Very good. And I'm not going to introduce all the panelists because you guys have been on stage most of the day. Lisa, again, welcome. It will be one of our keynotes to tomorrow. But I want to get the panel's reaction to, again, Texas, a little bit different. How do we take these ideas and get them to scale in our state?
Can I ask a question for you guys too?
Yeah.
I'm really curious about the data that you have and have access to, because I know that's one of the things that we really struggled with early on, but then wanted to move to. So I'm really curious about what your thoughts are on that, and how, and not to just jump right into the tar baby, but I think that's, to me, figuring out how to get teams access to data that works is really hard, and you guys are a really big state with a lot of different bits, so trying to figure out how that might work.
First I'll just say, wow. We've got a ways to go, but we've got a good start already. The rapid response data, I think Carrie, I, and John and others have talked extensively about that it's really important to have that carrot to put out there. We can track something and show them we've had improvement, whereas doing things quarterly is real time. And relying on health statistics that take a while to get in is problematic. So I think one of our limitations right now is there's a lot of different data streams coming in, and we don't have a central way to handle that yet through the collaborative. And we've talked about that previously as well. And Carrie and I and John were having a text dialogue in the last half hour about how do we get what you have?
I think that the thing is not to feel like you have to have this entire big system built overnight. I mean, we were literally just 5 years ago sitting like, Jay Imes, tell us how to do this. Elliot Main, tell us how to do this. How can we possibly build a data system? I mean, we were just there, and I think that we have 117 hospitals, which is still big relative to some states, but not the scale that you guys have. But what you've already been able to accomplish, you really have to realize how far that you've come. And I think that that's the other thing to realize. You have motivated folks who are bought in. That's a huge part. The number of people who raised their hand that said they're working on hemorrhage, and the ability that you've already had these meetings where people have been broken down. I mean, I feel like you've made an incredible amount of progress. So you're really well positioned. And I think Jean, who goes around and talks to lots and lots of states, is shaking her head. Yes.
A quick follow-up question on the data, the vital statistics data. Do you have that data? Are you working with the state? Who's providing that information back? How is that data managed and play between you and the state?
So we really don't use vital statistics data in the collaborative because we're excited when we get some vital statistics data. Like, we just got vital statistics data from 2017. We're like, wow, look, it showed that we improved. But we don't consider that, that's not the collaborative data. The data really, the collaborative data is the hospital's data. And so the hospitals really feel a lot of ownership of their data. The hospitals know that it's their data. They voted 2 years ago that each regional network wanted to share it with their regional perinatal network administrator. But we don't use vital statistics data because it's so far out from the QI. We have data we only focus on the data that's right in front of us. And so we're really, like when I was on the call on Monday with the MO teams, this is where we are. This is what we need to look at. Look at the fact our MAT is not improving. We didn't think it was going to. We've got to really, how are we going to change this data? So we use data that's present. We are really thinking about those process measures and the data that we can see month to month. The vital statistics data, I think that people it's delayed, at least in Illinois. You guys may be faster.
No, we're not.
So it just isn't meaningful. You can kind of be like, because, right now I can be like, well, that was in 2017. Like, that's not where we're at. It doesn't apply to the QI work that I'm doing in front of me. But if you tell me that we had, we only hit time to treatment on 50% of our patients in January, then in February, I'm going to be like, okay, what happened? Let's work on that. So if we're just trying to use data to drive quality improvement, you have to we really had to change the way we thought of data. And it was really, and that's why we use these wave one teams, because it's really, what is it going to use to drive the quality improvement? Not what's going to make us look really good later. There's lots of data we'd like to have, but what is the data that we need, that the hospitals need to drive the quality improvement? And I think that you can use vital statistics data, and I'm not to say that you can't in QI, because there are a lot of states that use vital statistics data because they're trying to figure out ways to collect data at low burden, and there's states that use hospital discharge data. We just couldn't figure out a way to do that in Illinois rapidly enough to drive the quality improvement. So we just made an executive decision that we were just going to use REDCap, collect data directly from hospital input, and because our hospitals were so bought into the process and really wanted that data, and they didn't see it as, oh my God, I can't believe I should do another initiative and send data somewhere. It was more, this is an initiative, and they're giving me a free data system with free data reports. It's like a compliance monitoring tool that my hospital doesn't have to pay for. So it's a very different way of looking at it, but that's what we chose to do in Illinois. So it's not that you can't use vital record data, it's just not very fast.
And Dr. Epps, you were chairing our data subcommittee. It looked like you wanted to jump in here, and then Amanda, Dr. Hall jumping in. Any thoughts related to that whole area of data?
I just kind of wanted to kind of share and kind of Anne was saying, that when we have looked as a group at specifically around obstetric hemorrhage, we moved that one forward using the AIM data portal with the understanding that those hospitals that were going to participate as an AIM Plus hospital was actually committing to doing monthly additional measures to help drive the quality improvement. So we're looking at the data from different ways with that understanding that we need that more real-time look on a monthly basis.
I was just going to say, it seems intimidating, obviously, when the data that you put up is all of these things, but we have to start somewhere. And Julie, not to, I feel like no one's ever going to give me a mic because I keep randomly calling out people, but I don't know if you have any thoughts on this from, I think, what we saw with our first cohorts and all of you guys coming, and just, I think, the enthusiasm and what hospitals are willing to do very quickly. Like, for example, how many people's hospitals are participating in disrupt maternity measures? Does anybody here know? Okay, so that's a ton of data collection coming from the hospital. And what about how many people get some percentage of Medicaid funding at their hospital? So we have to report potentially preventable conditions like postpartum hemorrhage and transfusion. So that's data our hospitals are getting. I think we just, and you know, this list can go on, right? Joint commission measures. How many of us are collecting NTSV and exclusive breastfeeding? And we're all collecting them. I think it's just now we will have to figure out how to get them into coordinated ways and have a place to put them and share them. And I imagine we will get there soon. It's just we are starting somewhere and knowing, you know, even just in those learning sessions, explaining to people where they get their severe maternal morbidity codes and realizing those came from our hospitals. Now we just have to learn how to, instead of having them pushed out to different entities, having hospitals own them and be able to put them into an area that we can share and work with them. Obviously, that's the hard part, but I think we all can do that.
And starting
together.
small, I think you were talking about, I think you were nodding your head when everyone's saying the word small. Because that's the thing that you want to give some people success, but not overwhelm them. So if you're trying to collect data on multiple niches at one time, or like multiple things, because there's so much to do right now with severe maternal morbidity, if you can start small, you know, we started on 10 birth certificate, 10 items on the birth certificate. We started with 10 birth certificate items, and Jean remembers when we were doing birth certificate. So we started really small, and we just were collecting data on looking at 10 charts per month on how you did on birth certificate. I mean, that's really small, but it just was a way to test our data system and to start seeing if it worked and to give people some success. So I think starting really small, using data that teams feel like they can use and help teams to see some success is a way to build a data system that people will want to use. And that's, I think, really essential. You know, at least if you have perspective on this from.
My perspective really comes more from a national level and seeing what a number of different states really have been able to do and the impact that the programs have in different states, and looking at their implementations and listening to the incredible success that we are starting to see across the country. And I think one of the most amazing things that has already been mentioned about Texas is just how incredibly quickly everyone in this room decided they wanted to be a part of the solution. And it has been absolutely amazing, and I could not be more proud to be speaking nationally and to be able to talk about how amazing our state has been and how amazing all of our hospital partners, our wonderful nurses, and all of our physicians and other providers have been to jump onto this effort, and to be willing to take that extra time to be a part of this incredible initiative. And, you know, Anne's talk today has been just really inspiring, and I love her energy and her cheerleaderness, and I am really excited about seeing that in all of us and hearing about all of the successes that each of you have had as you're starting to implement. I think, you know, we've got a great team in place to lead this, and they're doing just a terrific job, and I really look forward to seeing what we are going to accomplish, because we are going to reduce preventable maternal mortality in our state.
Right. We have a couple of microphones open, and we're going to open this up to anyone that would like to ask a question. I guess one question as we're waiting, well, Dr. Guillory, I will let you go first.
Just real quickly, Dr. Borders, you said you could start small, collecting, say, 10 measures and doing chart reviews. My question is, do you have to have an IRB to be able to do that? Or if you are, if you're reporting it in a de-identified fashion, do you still have to have it?
Yeah, so we do have so our data system, although you would never know this from looking at any ILPQC materials or being a part of ILPQC, the data system resides at Northwestern, because that's where I was when ILPQC started, and I got people to do in-kind development of the data portal. So we have our IRB through Northwestern, and then our teams can do the. I don't think any of our teams do IRBs other than our umbrella IRB. We do have data use agreements with some teams, but we offer a data use agreement, so we have like a very basic data use agreement that teams use. But because it's quality improvement, not all of our teams, and the data is de-identified when it comes through. We kind of have this like wall that de-identifies and keeps any identifiers on their side, and we are de-identified on our side. So we do have data use agreements with some hospitals, and it just depends. Any hospital that we're submitting to AIM, I guess that's how we develop most of our data use agreements, that's right. So I would say that we have an IRB for the data system. Most of our teams, because they're doing QI work, they're considered exempt. Can't think of a single hospital that does an IRB for this work, but we do have quite a few hospitals that have data use agreements signed with us, and therefore we share data. So none of our hospitals submit data directly to AIM. We submit, and Patty would know this a lot more than I do, but we submit our data for our hospitals to AIM. And then we also get some vital record data from the Department of Public Health that we share with AIM. Is that correct, Jean? Great. Yes. Yeah. So hopefully that answers your question. But it's important, and you'll see like at the National Network of Perinatal Quality Collaboratives, they'll be like, can everyone send around data use agreement examples? So there's a lot of sharing of DUAs and making sure that it works for different hospitals.
Hi, Dr. Bob Hillard. I run the quality, I oversee the quality people at the Texas Hospital Association, and I just want to congratulate you, give you my admiration for starters. My question really goes to, ultimately you've developed some fairly highly effective QI teams in a lot of hospitals.
Yes.
And you've standardized a lot of this, which really is a huge accomplishment. What do you do with two questions. What do you do with the poorly resourced hospitals, your smaller hospitals, your rural hospitals that may have turnover, may not have as many people as they need? And there really maybe another time to talk to you about getting this rapid data response as a positive reinforcement to data input.
So the first question was about how we manage our low-resourced hospitals. That's a really important question. So we have big hospitals, we have really small hospitals, we have hospitals that are in really isolated southern Illinois where they don't have close access to other big hospitals. We have hospitals that do very few deliveries, where we have one kind of nurse who's running the show and she doesn't have a big QI team around her. And so we really position ourselves to fill in the gaps for hospitals. We're there to basically build QI capacity with whatever a hospital is. So if it's the biggest hospital in our state, they still need to build QI capacity and they sometimes still need help. And if you're the smallest hospital in our state, but I think that's where the Perinatal Quality Collaborative can be really helpful at filling in those gaps in quality, and also the collaborative learning becomes really important. So you're no longer just like one nurse trying to manage a labor and delivery with 3 OB providers who've been doing this for 20 years and don't want to change, and a lot of staff turnover. you now have this big team of all these other hospitals who are doing the work, and you can throw things off of them and learn. You're not isolated in the work. You're also seeing where the standards of care are and how you can utilize resources from other hospitals. So our teams do a lot of sharing of documents and resources with each other. And so I think that work really, we always try to spin, like, how are we adding value? And so particularly for our small teams, in our small hospitals, you could imagine a small hospital saying, I can't join this collaborative because I don't have the resources to do it. It's just I'm one person. I can't take on another initiative. You can't understand how overworked I am. And we would come back to that and say, wow, we think that we are the solution, the answer to your prayers. Like, we're here to help. And you may think you'd have time for us, but we're here to, like, help you do all those things that you think you don't have time for. So I think that we've been able to turn that around so that instead of feeling like I don't have time to do this QI work, wow, I can do this QI work because I'm part of a collaborative. So I think that's how we try to look at it. I talked about it at one of the breakout sessions. When we did our hypertension data, when we broke it down by hospital, we track all of our data by hospital characteristics so we can see how our different types of hospitals are doing. And at the beginning of hypertension, you could see there was a significant difference on every single one of our measures based on patient mix, so Medicaid status, race, ethnicity, big, small hospitals, number of deliveries, and rural, urban. So it really mattered where you delivered based on whether you're going to get time to treatment, education, follow-up. By the time we finished our initiative, we didn't have a single measure where you could see a significant difference on any of our hospital characteristics. So really, by the end, we took everyone and said, everyone's got to cross the finish line. We don't care how we get there. We're going to get everyone across that finish line. We're all going to hit our goals. And so we were able to show that even big hospitals, small hospitals, safety net hospitals, we could get everybody there. But it's really about everyone working together so that no one felt isolated and alone in doing the work. So I think that's the message. We always are, I mean, again, it's the cheerleading. It's really trying to say this is how we add value, and then really showing that value added. And look, we always try to be really simple. Collaborative learning, QI support, rapid response data. Those are the three ways we add value for hospitals, regardless if you're big or small. There was another question, but I can't quite remember. Yes, and the question was how so we have a data team that is really smart, and we have a data programmer. And when we started, we met with the team. The data team met every single week, and me and the project director met with. We had a data team lead, and we had a programmer. And I could barely ever understand what the programmer was talking about. And so we set out to say, these are the things we're going to measure. This is what we want the data reports to look like. And we would, like, draw them on a piece of paper. And the programmer would go back and, like, okay, this is how it's going to. And they would do all the programming to try to figure out how to get the data. Because what we wanted, I said, I want a report that when someone puts data in, they immediately can look up and have the report in front of their face. And I want them to be a little button, and you can PDF it, and I want it to be shareable. So I was like, I want it to be rapid, and I want it to be shareable. And we want to be simple. People don't need, like, 14,000 reports. They need, like, 5 reports. And they need to really be able to put those up in front of them and figure out how are we improving every single month. So really trying to keep it simple, a rapid response, so that people can show success. We also were really clear, like, when we started opioids, we knew we weren't going to see success very quickly. We knew we're not going to get MAT numbers up very quickly. We really focused on those structure measures, and we made the dashboards go from red to yellow to green. We wanted our teams to see success. We wanted to be able to come up a month and be like, look what we're doing. We're implementing this screening tool. We're starting to get success. But implementing a screening tool is a long way away from getting a mom an MAT, but it's a start. And so we focused a lot in 2018 on these structure measures are moving from red to yellow to green to show success. It wouldn't have been very exciting if every single month I put up the same chart that was like, the MAT hasn't improved again. But we knew that was going to be the case. So we try to keep it simple, rapid, shareable, and also make sure that we're showing opportunities for teams to succeed. And these are just all things that I did not make up. These are all things that I learned from, like, Elliot Main.
That's very good.
I just sound really good saying them because I have to say them all the time because I go around. But really, this model that we put together was not something that we invented in Illinois. We took all these elements from what worked in Ohio and Florida and North Carolina and California, and we've just been able to package it in a way that we've been really focused on attention to those ideals. I think
But-
that's a question.
Well, one quick question, then a question from the audience. Much of the conversation appropriately has taken place, has been focused on hospitals. We also have birthing centers here in the state of Texas. And any thoughts from you or the rest of the panelists of what role do they play in this whole initiative to improve maternal health and birth outcomes?
Have they engaged?
So we are in the process of engaging. So one of our task force members is Nancy Jo Reedy, and she is a certified nurse midwife. And this has been something, as we kind of started down this process, she really very passionate about and wanting us to really think about the role of the birthing center. So she's helping us right now engage other kind of champions in her arena, as well as champion birthing centers that want to be a part of this. And so we've been having some phone calls. We're looking at identifying those champions that are going to lead to a pilot. And then our goal is then to implement a pilot within birthing centers here in Texas around obstetric hemorrhage. So yeah, so we have our experts that have been helping us with this, and now it's what does that look like within the context of a birthing center as we kind of move forward.
Thoughts from anybody else?
I mean, I think it's extremely important. I think anywhere that you're taking care of a pregnant woman, you know, even at home, and we know that that happens. And I could say that at Bentab Hospital several years ago, we kind of launched a initiative to just let the community know that we offered VBAC. And I can't tell you what kind of interesting response came with that. One of which was that women were coming from home or birthing centers to try and finish out their VBAC with us. And I just had no idea that that was even happening. And so we reached out to the birthing centers and the midwives and met with them to try to have a more formalized process for making that a safer transfer of care. And they were extremely appreciative and extremely engaged. So I just see this as another step in that same process.
A question from the audience.
Couple of comments and a question for Dr. Borders. First of all, I would really like to commend the physicians on the panel, because as a nurse leader, I would love to have physician champions like any of you in the facilities that I have been in. And not that I haven't had some, but your passion is certainly makes us as nursing leaders to partner with you to get these things accomplished. It helps just even in the challenges we have in finding the resources to do all of that, regardless if it's a small or a large facility. Resources is an issue. It always is. So thank you for your passion, and please pass it on to everybody you touch. The other question that I had regarding the MNO initiative that you started, are you screening all patients? Are they consented? And then how is mandatory reporting to CPS for positive screenings affecting your initiative?
So one thing that's really important to know is that when we talk about screening, so we've been trying to really be clear that there's a lot of confusion between testing, urine testing, and doing a validated screening tool. The ACOG committee opinion recommends universal screening with a validated screening tool. So the 5 Ps, the NIDA quick screen example. And we have about 4 of them on our toolkit that are considered validated screening tools that our teams are using. The urine, we call that testing. So we differentiate between screening and testing. And when you're testing, you're going to be consenting patients, consenting them for what a positive test is, and then you're going to be reporting it. The OUD validated screening tool is a risk assessment to look at women who are at risk of OUD, and then doing a brief intervention evaluation of what their issues are, and then referral to treatment. As part of the checklist, women would be consented and counseled about getting a urine tox screen because they've been considered at risk for OUD. But the validated screening tool, we don't consent for doing the validated screening tool. We're universally doing that with every single patient as a standard of care recommended by ACOG for all patients early in prenatal care and arrival into labor and delivery. That if someone's screen positive, then that would trigger a urine tox screen, and that you have to counsel patients about and consent them to do the urine tox screen. And then we also review with them the guidelines for reporting. One of the things we really want to work with our patients on is that by getting engaged in care, getting linked into MAT, getting linked to recovery services, behavioral counseling, and then having regular tox screens, that's really building a case for moms to get to go home, engaging moms in the hospital and eat, sleep, console, doing non-pharmacologic care, putting that safe discharge plan together. Those are the ways that we build a trail to get moms to be able to stay with their babies. Moms who are on MAT, engaged in recovery services, those moms are going to go home with their babies. And so we're trying to really partner with patients that by coming in and getting engaged in care, we can help them have the very best pregnancy outcomes possible, and build a plan that's going to be able to keep the mom and baby together, which is our goal. So it's not that that's without wrinkles. It's not that there aren't moms out there who are avoiding prenatal care, but by putting a universal screening tool in place, it normalizes it just like it does for perinatal depression screening. You know, when you're a pregnant woman, you're going to get screened for perinatal depression. We want everyone to be screened for substance use disorders when they arrive into prenatal care, and again, on labor and delivery. So does that? Yeah. So it's just a shift of mindset. We say that old way of thinking. Our old way of thinking is that we needed to screen moms who we thought looked suspicious with a urine tox screen so that we could find babies who are at risk of NAS and tell peds. So that was old way of thinking, right? And when people start talking about screening moms, they're really thinking about screening moms to find babies so that they know who they should be telling peds about. The new way of thinking is this is a chronic disease, just like diabetes. We need to identify these moms as early as possible so that we can get them the treatment that's going to save their lives. And get them into care so they have the best pregnancy possible, and have the best mom-baby outcomes possible. So that's just a big shift, and a lot is packed into saying we're going to start screening, because you have to shift from old thinking to new thinking in order to make a universal screening program effective. You see I have all these little sound bites, because I say this stuff over and over and over again.
Sure.
Just on a practical note, I was trying to double check myself, so I know there are a couple of people in the audience who are experts in this, but for our state, we have a couple of different things that are already we need to tack into and tie into for this. Obviously, that is a broad statement, but I mean, for example, I'm pretty sure that one of the disparate measures includes behavioral health and screening, and includes substance use screening universally with a validated tool. So in theory, we're all supposed to be doing that already. That gave me the impetus to build it into my hospital electronic health record in a way that was easy, because it's tied to DISRIP. So I think that's a tool that can help us all. And I think there might be language in the rules about behavioral health screening, and I think that's another important thing to verify, and will give all of us the tools to help make our hospitals help us with implementing it, because it's a statute and it's a quality reimbursed measure. You can't get much easier than that.
Because if you can implement universal early screening with a validated screening tool, and you get teams to understand that protocol, that nice flow waterfall kind of thing that we have, that's like the most important thing. We were realizing in 2018, a lot of our teams were so focused on getting the screening tool in place that they were just like, I screened them. Yeah. It's like, oh my God, yes, you've got a screening tool in place. But the women were just going on by who had opiate use disorder, and they were still just be like, and the screening tool is connected so it alerts social work and it alerts peds. And we're like, oh my God, we got to come back to the protocol. We're identifying moms because moms are dying, and we've got to do something different. So we want to make sure that we're implementing this universal screening, but we also really need people to do this culture change around understanding how we're identifying moms and why, and what this OB protocol looks like, and what's us as OB providers, nurses and physicians, what's our responsibility to these moms. But the fact that you guys have that in place, just implementing universal screening and trying to figure out how to link in the protocol of engaging moms to MAT, behavioral health services, and some of these things like Narcan, Hep C screening, and some of the education things, you've got a good start. Like if you're already doing those things in some hospitals, getting those other key components are not that hard. I mean, we went from nothing and just a lot of urine tox screens on labor and delivery. So we really had a long way to go. We still have a long way to go.
Got a question right back here.
I'm just curious. We already have a difficult time getting patients into behavioral health programs and MAT programs. Do you have a sense of, is your data of getting people into programs resource-driven?
So we have problems too. So we're spending a lot of time working with the Department of Health and DHS talking about where we're finding places. So our teams are supposed to email info@ilpqc.org when they identify patients that they can't get into resources, and we're supposed to be reporting that up to the Department of Public Health. It's hard. I don't think that there's any easy way around it. And when we do our missed opportunity, we have this missed opportunities form for OUD, so that if a patient comes through who is not on MAT or didn't get behavioral health services counseling or in a recovery services, they go back and they're supposed to look why. And one of the things is like there was no, we offered, we counseled it, but we couldn't get, there was no one available. We couldn't get them referred. So trying to figure out what resource like deserts you have and where, we just don't have access. One of the things we tried to do to get around that was doing the mapping tool. So we asked every single hospital in the state to map their local resources, so at least they have a starting point. And if they still are having a lot of struggles, we want them to reach out to us so that we can kind of go up the chain and really talk about it. The other thing we're then asking them is to try to get a provider trained and get a buprenorphine waiver so that they have someone who can at least start it at their institution. So that's our goal.
And I just wanted to kind of make a few comments, and I think we were like feverishly taking pictures and notes as you were talking about the work y'all are doing around the opioid use disorder, because we're moving forward with that, but at a smaller scale. We have had our work around the obstetric hemorrhage, and we're working towards that opioid bundle, but in a pilot phase.
Totally, it's the right way to do it.
And so we're going to do it with a smaller group. The hospitals that who have said they're going to do the opioid bundle with us are also hospitals that are AIM Plus hospitals. So they have really made quite a bit of a commitment around this. And so we're moving forward in that direction. And I think the other thing that we're also doing kind of simultaneously, this is also within my area, is that we have recently gotten funding from the CDC. And this is to do work around opioids, and one of the things that we are doing is we are working with the UT San Antonio around increasing the number of providers who are waivered here in the state of Texas, and so we're working on that now. And then there's also some work that's being done around naloxone training for public health folks, and then how can we enhance data here in our state? Work around surveillance, GIS mapping to have that understanding of how where we are in our state, where those resources are. And so I think that those are opportunities that I'm also seeing, and as we're continuing to move forward in this arena.
Other questions?
I actually have a question, kind of shifting gears a little bit for Dr. Borders. I was wondering if you could elaborate more on how you get patients involved in the QI initiatives and how you select them and what role they have.
That was like a whole thing. We had a PhD. We get a lot of interns who come through and work with us. We get medical students and FEM fellows and PhD candidates and MPH candidates, and so we tend to give them jobs. It's free labor, which is really nice. So we had one PhD student from the Harris School of Social Work who spent her year really working on this topic with us. And it's one thing for us to say, like, hey, hospital, go out there and get a patient on your QI team. And you're just like, where do I even start? Like, do I just walk up to someone and be like, hey, you want to join our QI team? So we really struggled with this. And one thing that we started doing was reaching out to advocacy groups. So we started with the Preeclampsia Foundation and March of Dimes, who have patients who are already really motivated, and they actually go through training. Like Preeclampsia Foundation trains people to be advocates and sit on groups like this. And so we were really successful with getting March of Dimes and Preeclampsia Foundation to put us in contact with patients. And we actually did a matching program where we had, I think 10 patients from the Preeclampsia Foundation who wanted to serve as QI advisors, and then we just figured out what hospital they either lived close to or where they had to live, just tried to find some options for them, and then we reached out to that hospital and was like, we have a patient who's been trained to be a QI advisor who wants to serve as a QI advisor. Would you be willing to have her on your QI team? It still doesn't make it easy, because I would say that those hospital teams are really scared. They're like, I don't really want, they're like, a patient, like sitting here when we're talking about all the things we're doing wrong? Like, that seems totally like the opposite. We put on our happy face in front of patients. Like, what are you talking about? So it was a big learning curve. We try to expose our teams to as many patients as possible. So we have patients can come to all of our meetings for free. So face-to-face and annual conference, we're like, bring a patient. So if someone, it doesn't matter who they are, they don't actually even have to be like an active official member of your QI team. So we ask them to bring a patient who potentially is going to be on their QI team or on their QI team. We do a breakout session for patients at our annual conference to teach them and talk more about being an advisor. We still struggle with this. It's not like we have solved all the problems. We developed a little tool, like a little that you could hand out to patients in the NICU or on postpartum that just says what a QI advisor is. If you're interested, give us a call. We developed a welcome packet when you've got a patient, how to explain to them what you're asking them to do, and then some easy little jobs you can start out giving them to do, review your patient materials. So we tried really hard. I mean, we put these full packets together, and still it was like pulling teeth. It was really hard. North Carolina had this real shift in engaging patients, and then almost all of their hospital teams now have a patient advisor on them. It's just this I think you just have to keep, it's like me telling my, kid that they have to try, Brussels sprouts 14 times before they like it. It's like you just have to keep going back to it. And I think the more that our teams see patient advisors actively engaged in ILPQC, they serve on all of our advisory work groups. They speak at all of our conferences. And so you just start to hear the patient story is really important. And patients actually have a pretty good perspective on what went on when they were at the hospital, in the ICU, in the NICU. And so they actually can really add value. It's just a trust factor. And we also have had some administrators who felt uneasy about bringing patients in. So we've just had to figure those issues out. But I would say go to your advocacy groups. They're really engaged right now and really interested. There was a group here today, Mama Voices. Are they still here? Anybody know about that? So they were here today, Mama Voices, and they're trying to get a bunch of different advocacy groups to all link up together, like preeclampsia and Akrita and, everybody. So I think there's a lot of groups out there, and I think there's a lot of opportunities to find patients. Some of our teams have just found patients that they thought were smart and interesting who came through their hospital and said, hey, who had an experience and said, if you're ever interested in being participating in QI, give us a call.
All right. Well, we are unfortunately out of time. I want to thank our panelists. Dr. Borders, again, thank you for coming here and sharing your experience. And thank you for the stamina of everyone in the audience. We've been going for 12 hours. And we will resume in less than 12 hours. And so please get a good night's rest at 8 o'clock tomorrow morning. Is that right? We will commence and start day 2. So thank you very much.
It was really fun. I'm so glad I got to come. You guys get to see the whirlwind of ILPQC.